Hello, welcome to ACI 2017. I'm Bob Gerber, an interventional cardiologist from the South Coast in Hastings and Eastbourne. And today we're going to talk about the bifurcation stenting, following on from the great session yesterday dedicated to the bifurcation stenting. And I've got a panel of experts with me. Over to my right, I have Dr. Miles Behan from Edinburgh. He's an interventional cardiologist. We have Professor Dave Hildick-Smith from Brighton.
Hi.
And Professor Adrian Banning, who is president of BSIS and also a professor in Oxford.
Hi, Bob.
So what we're going to talk about is some of the two-stent techniques. And really, there are a lot of two-stent techniques. And what I'd like to tackle, particularly as a practicing cardiologist, I'm always confused. When do you culotte? When do you DK crush? When do you crush, mini crush, big crush, small crush? And the so-called shotgun that we tend to refer to in BSIS, which is the SKS type approach. So let's go to Miles.
Yes.
You've established that you're going two stents. Can you just give me a roadmap as what's going through your mind?
Well, it's really about assessing the lesion again, and the bifurcation angle is the size of the side branch, and the disease in the side branch. If there is a very wide bifurcation angle, then a T-stent a reverse T may work very well. However, if I'm concerned because of the angle is narrower, then I would probably go for a culotte. I tend, and I think most people in a planned two-stent strategy would aim to treat the side branch first, just because that way it makes sense, and also then you've protected the side branch. So I would tend to probably go for a culotte if it was a narrower angle.
Adrian, if you were doing a two-stent approach?
The vast majority will be culottes. I mean, I think the only problem sometimes is as you've illustrated, if you've got a big angle, perhaps you might not, of the really big size mismatch, and that's sometimes a bit more problematic. But the vast majority of bifurcations, even acutely, I think you can sort it out with a culotte.
And if the T was mentioned, is that sort of out? Is it more of a tap?
Yeah, well, tap is a kind of bailout strategy, isn't it? Where you've set out to do a single stent approach, and the bifurcation, the branch is not optimally, is not optimal, and you need to put a second stent in. And under that circumstance, the tap is a very straightforward bailout procedure, and it gives a good result.
And that was the question I was going to ask you, David. If you're going single stent, but you've decided you're going to go two stent, when do you make the decision you're going to do second stent? And also, there is some data which I think you've told me in the past as a trainee about pressure wiring in side branches and so on. And B, if you've made that decision on this criteria, what's your preferred, reverse crush? Is there reverse tap or a reverse culotte? I guess are the three potential options.
They're really sort of provisional tap, provisional culotte in a sense, rather than reverse. But so the time when you would decide you're going to do two stents is you're provisional, you've done your stent, you've done your pot, you've done your kiss, and now the side branch, which is big enough to save, looks ragged, dissected, either potentially closed.
So angiographically or...
Yes, angiographically.
So any clinical pointers such as ECG change, chest pains, that sort of thing?
Sure, those are not good either.
So if you have a normal angiographic appearance but the STs look a bit funny, does that change anything, or you just a bit nitrate?
Yeah, usually give some drugs and wait for a bit and try and work out what the cause is. But I mean, your indication from the studies to go in with your second stent is dissection greater than trivial, and loss of flow, or threatened abrupt closure. So any of those scenarios, you will want to secure your vessel with a second stent. And for me, and I often say this when I do a talk on this, I think even if you're someone who does quite a lot of stent procedures in a year, let's say you do 300, and 10 or 15% of your cases are bifurcations, that's 40 odd bifurcations a year, And really only 1 in 10 of those is likely to be such a big bifurcation that you would really consider putting the second stent in. You're probably only going to do 3 or 4 in a year. So the idea that you could have up your sleeve tap, culotte, DK crush and all this probably is a bit fanciful, and we're more likely to make errors like that. So for me, I will routinely now do a mini culotte. It's not the kind of culotte that Chevalier described, where it really is trousers, with a lot of double layered stent in the main vessel. It's only really a few millimeters of true double layer in the main vessel.
And a mini crush?
I wouldn't, I've abandoned the crush a long time ago because of the fact that the crushed stent is not uniformly in a nice bend into the side branch. It's curved in. There's a no man's land where you can rewire into, balloon, and just make it bigger and bigger, a larger and larger area of vessel that is not covered by stent, which you're progressively mangling. So for me, I appreciate there's been a lot of work from China on the DK crush, and very good results have been obtained by particular individuals, but I think it's yet to impress or persuade people in Europe that it's got a good role.
Adrian, as the DK crush left main data and versus culotte, as a counterpoint, I appreciate DK crush is not a crush because it's more complex and there's more steps involved. Do you think it's a strategy to use?
It's an interesting strategy, isn't it? But is it a mainstream strategy? Not for me, for many of the reasons that Dave said. I think one of the things that we need to do with intervention is always to try and make it more predictable. And the problem with crush was that ultimately it was unpredictable, and the key unpredictability was, can I get back into the side branch? And if you can't do that, then you're in a bit of a mess. DK crush was designed to make sure that the ostium of the side branch was likely to be open, and to make it easier, therefore, to kind of do it. I think, done by experts, it's an elegant technique. But for me, by treating the most affected vessel first, culotte is a predictable technique, particularly if we add pot to it. And I think by placing your first stent, by doing a pot, by then rewiring, you're basically taking away areas of unpredictability. And I think it's all about trying to make everything we do predictable. And I think one of the things that you mentioned a moment ago is, you've got a bit of chest pain. The chest pain is, but the angiogram looks fine. So I went on to put a second stent in. I can guarantee that chest pain was nothing to do with the diagonal. And people get themselves in a tangle because the patient's got a bit of chest pain and they're not sure what's going on. We must be slower. We used to think by being fast we were somehow better. But actually taking our time and making sure that the result is good has to be the kind of mantra from now on, I think.
Yeah, and I think with the 2-stent strategy, being meticulous, as you should be anyway, and systematic is important. And then you have to kiss. I mean, a kiss, it's not acceptable not to kiss, I'd have thought.
So what I want to do, as chairman, I want to pin each one of you down as to your hierarchy on the 5. So the DK crush, the culotte, the crush, the SKS and the tap. Miles, give me from priority 1 to 5.
Well, to upset you, first of all, I'm going to say number 1 is provisional. Okay, but which you didn't give me that strategy.
Because we're talking 2 stents now.
Yeah, so then I would probably go culotte, T, DK crush, although I don't think I've even ever done DK crush, to be honest. And then the others are so far down the line. I think what's important for me is being able to do the technique that you're going to use and doing it very well. So you should be familiar.
And Dave?
Yeah, I mean, culotte in big letters, tap in very small letters, and then the other 2 are invisible.
And SKS?
No.
Never?
Well, I've never done it. I could probably conjure up a situation where I might once in my career think it was a good idea, but that's about it.
Adrian?
I'd never do it. I would never do it.
And your hierarchy?
It's the same.
So
I mean, Julian Gunn makes SKS look very nice, and he seems to get very good results. I intuitively just don't like it. I can't say that I'd ever spend enough time to become an expert at it. And I think if you are working in an emergency situation using the techniques that you're familiar with, you will get a better result and be more comfortable. And that's what I do. And so I've had cases with a blocked left main, both branches are down, and somebody would say, oh, SKS is the thing to do. If I've not done it before, this is surely not the time for me to start to do that.
Yeah.
I'll just do what I normally do, and actually, it doesn't take that long. One of the things that I think we're also a little bit bogged down with issues about the culotte, that it's difficult. It's difficult to get the wire back across. You've got to use a new balloon to kind of get through the stent. These stents now are much easier, they're thinner, the bigger, the aperture is bigger, the balloons are better, they collapse better. Yeah. And actually, it is much, much easier than we remember from 10 years ago. We're kind of burdened with a little bit of that, and we just need to kind of shake it off. And actually, it's not difficult.
So we're often taught to do a kiss. And what I want to talk about now is what we need to do a kissing balloon inflation after the procedure, or with a DK crush needs to be before as well. Miles, what can you give in terms of practical tip if you're finding it difficult to do the kiss? You're doing a culotte, that's your technique, the thing you're happy with, and you've got a wire and you're struggling. What can you tell us? What should we do?
So it depends where the wire is, but I think if I have got a wire down, so say that if we've done a culotte, I've got a wire down, say a large circumflex, and I'm struggling, I've got a wire down the LAD, and I'm struggling to recross back into the circumflex. Yeah. That's when a pot is very helpful. You want to do small things to try and open up those side branches.
And do you use a short length, upsize balloon, high pressure? Is that what you would do? Proximal to the area, or
do a pot?
Yeah.
Try again.
Yep.
And then I would just get another wire.
Right.
Try it in different wire.
Change it. So
actually
what wire do you use?
pushing is, it doesn't matter what wire you use, but pushing these days with the balloons that we have will usually tell you that wire is not where you think it is.
Yeah.
And it is remarkable how often you take another wire and the balloon just pings straight down. And that meant that first wire was in the wrong place.
Do you have a favourite crossing wire? Is there one that you use? Would you have a Whisper or a Pilot, or would you go with a non-coated wire?
I always go with cyan blue to start with, and I would usually then go to a Pilot 50 when I'm struggling. I just think it's if you can get across without having to get a Pilot wire out, then I think that's the better for me.
David, if you're doing that, do you take the wire, let it fold on itself, and come back and try and flip into the distal cell? Because that's the other thing that we're told we should try and do, and there's a little bit of kind of witchcraft. Am I actually in the right cell? And sometimes even if you look angiographically, it looks okay, and then the balloon's struggling, you're thinking, or maybe I'm in the proximal cell. Do you have a favourite wire, and how do you try and make sure you're crossing in the right part of the stent?
Yeah. So key to that is you've done your stent, you've done your pot. You leave your two wires in place. This is for a single stent strategy, but you want to kiss, okay? So you've left your two wires in place. You take a third wire, having done the pot, not before. If you can, you prolapse that wire through your left anterior descending stent, distally, so you're very happy, okay, I'm definitely not behind the stent. And then you pull back, and sure, you try to go for the distal stent strut, but
so yesterday you used a run through.
Yeah.
And is that your go-to wire?
Yes, I really like the run through wires, either the extra floppy or the hypercoat, and it's relatively unusual that you need a wire with much stiffness, having done a proper pot, to be able to get through into the side branch. Just occasionally, but
what about one-to-one steerable, like the Scion that Adrian was talking about? Are you? Is that one you
I haven't used the Scion Blue that much, although I've been impressed when I have. I think, obviously one-to-one steerability is lovely. And some wires are certainly probably better than that. In the vast majority of cases, it may take you a minute with your wire that you're very happy with. That's a minute well spent.
I think one of the things is looking after the tip of your wire, isn't it? I mean, it doesn't matter really what brand it is. If the tip of the wire has been bashed into the stent because actually your guide catheter wasn't, particularly with a main, you sometimes find your guide catheters out, and that was the problem in the Stoke cases today. So the tip of the wire just wasn't ever going to cross. And you just got to be sure that you've got axiality of the guide so that the wire emerges into the stent and it's then fit for purpose. If you've got if your guide catheter isn't aligned and it kind of backs into the back of the stent a bit, particularly if you've got something like a pilot wire, well, it's dead within 3 seconds because it's bashed into the back of the stent and it's gone.
In terms of escalation strategy, do you use microcatheters? Is that something that you have
This is for getting into the side branch?
Yes. So we're just talking about side branch problems. In the scenario where you've actually got a stent, so in the culotte scenario, or even if you'd done a tap, say, because you're worried about side branch going down, with the intention of doing a provisional, and then you must kiss in this instance, and you want to go back into the side branch of the T stent, and you tried all the things you've done, you can't get through. Is there anything else? Could you put a balloon? Do you put balloons in the main vessel? Or you hear of a lot of things. It's just...
No, I mean, I think the main thing that if you're trying to take a balloon into your side branch in the situation that I think I've understood, and it's not going, one of two things has happened. Either you have managed inadvertently to put your wire in the wrong place, or you haven't managed to open up the lattice of the stent sufficiently with the pot to allow the balloon to go through easily. So my first step in that situation would be, again, to do the pot. Perhaps look at exactly where I'd done it. Had I done it far enough into the main vessel stent? Had I really reached the carina? Because if you push out the struts and make that kind of bay window into the side branch, really your balloons ought to pass pretty straightforwardly.
And Miles, the KISS. What sort of balloons do you use on the whole, and how do you do? It's a bit like cooking pasta, isn't it? How, what inflations do you use, and what sizes? And,
is there an al dente balloon?
Yes, the non-compliant.
Yes.
So I would use 2 non-compliant balloons. I think one of I do tend to do inflations in both arms and then together.
And do you? The reason I use pasta analogy, some people deflate one and the other. Some people deflate them together.
How is that pasta? How do you?
Well, it's just that how long do you boil the pasta for?
I see.
Yes. So I think it's I personally am just happy as long as the kiss is done, the inflation has been done properly.
Because it may not be the final thing to do. I mean,
No.
if you do, the hardcore EBC guys would like you now to finish with a further pot.
And it makes sense that it's going to be elliptical. You're going to pull
And it
some
comes
of that.
back to what I was saying about the prognosis being dependent on the main vessel.
Yeah.
But I think one of the things that people do agree on mostly is if you've got a 2-stent technique, particularly, then to do each ostium to really high pressure, to try and circularize the ostium, the stent mesh there, is probably very important. So you would perhaps do individual very high pressure inflations, followed by perhaps a lower pressure kiss to realign the neocarina. Whether it really matters at the end that the very proximal vessel is a bit elliptical, as long as you don't have bad malapposition, whether it's elliptical or circular, I think probably doesn't matter. But
The thing is, the other thing that I have evolved to is slightly longer stents to allow myself the distance proximal
that's very
to the
important.
bifurcation,
Yeah.
so that I can do pot or a final pot as well, but safely, and I'm not damaging the vessel in what is essentially a very high-risk area, if you like. So damaging the vessel proximal to the stent is really not optimal, and we need to be just thinking about that when we put our stent in, that we're going to have enough space, at least 6, maybe 8, to make sure I can get a balloon in, and you showed that very nicely yesterday in the case.
So Adrian, just to up the ante now, you've got a trifurcation. So we've more or less just focused on bifurcations. We do have a third vessel, usually a ramus or an intermediate, say if it's in the left main. But you can have those LAD diagonals or marginal systems where you have big 3 vessels. How can you help us with that? What do you tend to do?
I guess I've evolved. I I don't use 3 wires anymore. I rank the vessels in their importance, and I make sure that the top 2 vessels will be open at the end of the procedure.
And you don't wire protect the third.
I think I tend to agree. I think Adrian's probably right, because I think mathematically I can't explain this, but I think once you've involved your third wire in this process, before you've even considered rewiring stuff, you are multiplying your potential for cock-up. And if I'm faced with a trifurcation, as I think I said to you earlier, the least important vessel sort of has to look after itself, and the two that are more important get all the attention.
Do you chase that vessel if you lose it and it is?
The least you can make that decision based a little bit on how likely it is to be able to look after itself. So
of course.
And so my intention is to have 3 open vessels, but I think if you've got 3 wires and you're moving kit around, it just becomes very complicated. And the concept, way back, I tried to put using a variety of complex stent techniques, trying to stent all 3, and thought it was fantastic and thought I'd been really clever. They always come back. And they always come back because the stents aren't properly expanded. I think it's very difficult to expand 3 stents properly within a left main, even if you've done an awful lot of preparation, because actually there's just too much material there and you just can't do it properly. So I think...
And we have all seen cases at PCR where you have a big guide and the trissing is the way it's sort of regarded. Do you think that's just sort of macho PCI then, or?
Yeah,
I think it's old-fashioned PCI, frankly.
So there's trissing's out.
I'm dissing the trissing.
You heard it today.
But I mean, the case we did yesterday was it wasn't exactly a trifurcation, but there was a branch that we left. Nobody said, "Ooh, why isn't there a wire down that rather small circumflex?" Because we'd chosen it to be left alone because it was coming off at 90 degrees and it was the smallest.
Mm-hmm. And often in that, the vessel you're going to leave often is the intermediate. Often it's the easiest to get through because your stent, if you've gone into circ, will be on the knuckle and you can pick it up if you have to. And I just think particularly most patients I'm going to be trying to do from the radial approach, even if I've got a sheathless guide with a 7.5 lumen, I don't want 3 wires. I think I can manage with 2.
Right, Miles. So a little bit on stents in terms of stent choice. And also, there are bifurcation stents.
Yes.
And your views on the sort of stents you would be choosing for all bifurcations, provisional or 2-stent strategy, and also on some of the bifurcation stents that they're out there.
That's a big question. I think in terms of stents, I think bifurcation stent is going very basic. They have to be drug-eluting in my mind now. They from just in terms of how I pick a stent for any coronary lesion, I like deliverability, pacification. I then also want, for my bifurcation stent, because we're sizing to the distal main vessel, I want to make sure that the scaffold will be able to accommodate the proximal main vessel with a pot. So those are the main things and that's particularly important in left main stem, where you need to know that you're going to have the stent size will be able to accommodate going up into the left main stem from where you are. So in terms of that, that's how I pick. Those are the main things which cause me to pick my stents. Also, I want to be able to, dilate up the cells, and so some of it will be personal preference and my experience of different ones. In terms of the dedicated bifurcation stents, the experience I have is with the Axis stent, which actually, the interesting thing about the Axis stent is it's taught me an awful lot about the carina when you use it, because you do have to really appreciate the carina when you deliver it. It is bulky, it is 7 French, but you do get some very nice angiographic results with it.
The other bifurcation stent, obviously you said you don't use...
I don't use, I have very limited experience with
metal,
Triton.
So Triton's probably...
although that's got a very nice technique to it. But,
and as you said, the number one procedure you would do for a 2-stent would be a culotte, and it facilitates that.
Yeah.
So the concept is there, I guess.
Although, I mean, they are there, but I think for me, just to reiterate, data and practice, I mean, tells me I go one stent.
So data, David, in terms of what stents we should be thinking of using for a simple approach, and then also the dedicated bifurcation stents. What's your view? Is there enough data yet to bring into mainstream practice, or
With the dedicated, you mean?
both
or with,
as well? You know, we hear from companies about their stents being better at opening the cell into the side branch sort of thing.
So all the stents are excellent. It's a mature technology. We have some really, really good design stents now. They're not all exactly the same in terms of the opening into the side branch. And I think one area where it's particularly important to know your stent is for the left main, because you will be putting in a 3mm stent, and it's no good if that only goes up to 375. Because back in the left main, you need quite a lot more than that. So you do need to know where the cutoff is for each of your stents. And I think that's much more important than which stent theoretically has a better opening the side branch. You can get through them all. In terms of the dedicated stent, it's just a bit of a tragedy, really, for bifurcation science and engineering, that it's just so damn difficult to engineer and create a bifurcation stent which really does just go down both vessels and stent them both. It's, I mean, 10, 15 years ago, there was a Bard XT, there was then another company was developing a true bifurcation stent. It's just proved too hard. And the results with this single stent, unfortunately, Nordic and BBC One kind of killed that a bit, because the results with the single stent were so good that it was almost impossible to envision a study where a dedicated stent won against the simple provisional technique.